To my personal number? No. It's here.
No,
It's here.
WhatsApp group.
Okay,
WhatsApp.
good.
Good evening, everyone. Welcome to the ASI. Dr. Siddesh, we are online.
Yeah.
Good evening,
Good evening,
everyone.
sir.
We will be starting our ASI time today, and we have endoscopy program today. And may I request Dr. Rajgopal Shanoy to take over and get Dr. Marutu Pandyan, and then Dr. Praveen Suryavanshi, and then the proceedings to go on. Okay, Rajgopal
Very,
Shanoy.
yeah, very good evening to each and every one of you. Most respected President of the ASI, Dr. Marutu Pandyan, and entire top leadership, and our senior advisor to the Academic Council, Dr. Santosh John Abraham. And today's important topic, that is our upper GI endoscopy. This is the NSCP, basically National Skill Enhancement Program. This is our third academic program in this month. So it will be moderated by Dr. Siddesh from Mysore, and other four panelists. I give a warm welcome to all of you, sir. Govindaraj, Dr. Govindaraj, Dr. Satyapriya Sarkar, Dr. Joy Abraham, and Dr. Bhavnik Bhalla. So without taking much time, so may I request now our President of the ASI, Dr. Marutu Pandyan, sir, please brief the audience. Thank you.
Good evening, all. Respected Vice President Dr. Pratap Parute, immediate past President Dr. Praveen Suryavanshi, Honorary Secretary Dr. Gadi Divakar, the Academic Director Dr. Rajgopal Shanoy, past President and Advisor to ASI EC Dr. Santosh John Abraham. Today's session's moderator, my good friend Dr. Siddesh, past President and Director of Social Welfare Council. All the panelists, Dr. Govindraj, Dr. Satyapriya Sarkar, Dr. Joy Abraham, Dr. Bhavnik Bhalla. Really, I'm happy to note that all legends in the field of endoscopy is taking part in this program. They are doing endoscopy day out and day in. So really, it is a big gift for all the young postgraduates and the young budding surgeons to have interaction with these people. All of us know that endoscopy is the day of the order, where everyone should get trained in this. So hope the panelists will do their best so that each one will have a good knowledge on this endoscopy. So these few words, I welcome all the panelists and office bearers of ASI. Thank you. Thank you all.
Thank you, sir.
Over to
Rajgopal?
Rajgopal Shanoy, sir.
Hello.
Yes, sir.
Yes, sir.
Can we request Dr. Praveen to say a few words, please?
Yeah, sure. So, good evening, everyone. I welcome all the faculties and the viewers online for this very interesting session, which is very close to my heart also. And I really appreciate the things which were initiated by the Dr. Siddesh, then President, in year 2022. And it has taken a big shape today, that ASI has just introduced step 2 program. Not only that, we have now the state of the art training program at our Chennai head office, and now today is this NSCP program. Now it is, we need not to discuss whether a surgeon should do endoscopy or not. Now it is well understood, now it is taken up. So now ASI is doing further initiatives to train more and more surgeons for this purpose. And I'm very happy that under the leadership of Dr. Murdu Pandian, everyone is involved with so much enthusiasm. Even I am now excited to attend all the today's sessions. So thank you so much, all the faculties for joining us, and I am sure is going to excite many more budding surgeons to take endoscopy in their armamentarium. Looking forward. Thank you so much.
Thank you. Look
Thank
forward
you,
for your
sir.
comments at the end.
Sure, sir.
Thank you, sir. We'll have Dr. Bharti.
Thank you very much, sir. Respected President ASI, Dr. Murudha Pandian, immediate past President, Dr. Praveen Suryavanshi, Honorary Secretary, Dr. Gaddi Devakar, Honorary Treasurer, Dr. Madhumita Mukhopadhyay, Director Academic Council, Dr. Raj Gopal Shenoy, sir, Director Social Welfare Council, and the moderator for the today's session, past President ASI, Dr. G. Siddesh, sir, the academic advisor and the past President of ASI, Dr. Santosh John Abraham, sir. I welcome today's panelists, Dr. Govindraj from Trichy, Dr. Shattapriya from Day Sarkar from Kolkata, Dr. Joy Abraham from Ahmedabad, and Dr. Bhavneet Bhalla from New Delhi for this important National Skill Enhancement Program of ASI on upper GI endoscopy. So the learning upper GI endoscopy is no longer an option for the modern general surgeons like it used to be in our older times. But I feel it is a critical extension of the clinical examination like ultrasound has become. Its importance can be appreciated across the several dimensions like bedside diagnostic procedures and therapeutic procedures like catching of the bleeding, upper GI bleeding, removal of foreign bodies, early detection of malignancies. And at that same time, it often complements the minimal access surgery as a hybrid intervention. So I feel for the general surgeons of the present era, learning upper GI endoscopy is an essential skill to be acquired for the seamless patient care. I wish all the best for the entire panel for the wonderful hour ahead. Thank you very
Thank you.
much.
Thank you.
Desh, please.
Thank you, sir. I will share my slides. Sorry. Good evening, everyone. Without wasting much time, I thank the office bearers of the Association Surgeons of India for having given this opportunity to host the elite panel across the country to conduct this very important session on upper GI endoscopy for surgeons. And this session we have planned with the advice of our advisor academics, Dr. Santosh Janabram, and the Director of Academics of Association Surgeons of India, Dr. Raj Gopal Shanai, who are here. Thank them for immensely for this opportunity. And the aim of this, what we have kept is, I have personally tried to introduce the luminaries of surgeons who are doing such wonderful job as endoscopists and also contributing to the training of young surgeons in endoscopy. All these four are certain luminaries which would like. So introducing such luminaries will also go in a long way to enlighten the people, the surgeons, young surgeons and the postgraduates, that they can also look up and then become endoscopist and also expand their career. And also, we'd like to tell a few words about how ASI is contributing to impart the knowledge of endoscopy to its members and fellow colleagues. So today, let me introduce our panelists before we, with a short introduction. Dr. Govindaraju he is our country lead for Step 2.0 program, and he is from Trichy. He has got a illustrious career, and he has been, if you look at to his positions which he owns and the various qualifications, it runs into a long thing, but I will cut short. He has been a managing trustee and a chairman of institution, and also right now is the governing council member of the Association Surgeons of India. He has been right now the current president of the prestigious Indian Association of Gastrointestinal Endosurgeons, IAGS. So I would like to really thank you for joining us, sir, and giving your insight. And Dr. Satyapraya Sarkar, he is one of the veterans in this field of endoscopy. Being a surgeon, he has been a master trainer at IAGS and various other forums imparting knowledge of endoscopy. And he is also been the joint secretary of World Congress of Endoscopic Surgeons and Endoscopic Surgery in the year 2024, which was convened at Calcutta. Sir, you have been a consultant gastrointestinal surgeons at Nightingale Hospital, and you head the Department of Gastroenterology at GODI Hospital, Calcutta, sir. So I really welcome you, sir, and we hope we will have a good video session of how you show your tips and tricks to the youngsters. Dr. Navneet Bala is a very good friend of mine. He has been really a revealing personality, having shared several of my training program podiums, and I welcome him here. He is a consultant laparoscopic and bariatric robotic surgeon and GI endoscopist. He is the academic director, World and Laparoscopic Hospital, and associate editor, World Journal of Laparoscopic Surgery. And he has started his own endoscopy training center called TUX. So I welcome you here to say your way of doing therapeutic endoscopy as an introduction to general surgeons. With this, let me go ahead with few words of introduction to the audience today. I hope essentially it is aimed at young surgeons who are looking up to become endoscopists, and also residents, what they can look up in the field of endoscopy if they plan to get trained in endoscopy. The impact of endoscopy, which you all know, it helps in diagnosing diseases accurately. It helps in early diagnosis. It helps also in better understanding of the upper GI diseases, helps in staging the malignancies, and several therapeutic procedures, of which few of them we are going to introduce you today, can be performed. And it is, I feel, it's when it was introduced to the mankind, it was a horizon in the management of GI disorders to the whole community of doctors. And I will be failing my duty if I don't thank my guru, Dr. V.N. Shrikande, who is here, who has introduced me to endoscopy. And that's how endoscopy used to be done earlier days, through eyepiece and image cameras mounted on the eyepiece. And that is me, how I started doing endoscopy in the year 86, way long back. And there are several advantages as endoscopist, a surgeon would have, that gives an added edge to his practice, and it gives a comprehensive patient care and management in a single center, which he can provide. And it gives more confidence in managing diseases of the GI tract. It enhances practice economics and patient convenience. That is a real advantage to the patients as well. And minor complications, if at all, if they happen, you are in a better position to treat them as well. And hybrid surgery, there are several procedures which can be combined with your surgical procedure as well. For example, in diagnosing a site of a GI bleed in a small intestine, this can be of relevance. So there are several such procedures which used to be done either by open or laparoscopic surgery, has now been done through the endoscopic way. So we know the list is ever expanding, and if you don't get to know at least what is possible, there is no way you will become a loser in the long run. So keep aware of those procedures which are evolving, and only when you start doing the basic endoscopy procedures now, early in your life, in your career, then you can think also with a proper training to perform, if not all, at least few of the safe procedures which you can in your setup. GE junction tumors is one such example. As a surgeon, you would know, unless you do yourself, what is the margin of the proximal margin of the lesion and the distal margin of the lesion as well with respect to the GE junction. The various types of procedures can vary. So that is, as a surgeon doing endoscopy, you get the confidence to decide what procedure, either esophagectomy, it can be total gastrectomy, or it can be something else. So depending upon the exact site of the lesion, keeping the oncological principles. GERD is one such procedure where, we have seen young individuals, for years they have been treated with medical management with a presence of a large hiatus hernia, which you can, with a simple laparoscopic procedure in a well-trained hand, you can perform much to the long standing relief of such patients. Foreign bodies can come in present in various sizes and shapes. Those which have got very sharp edges and very bulky, they can cause injury to the esophagus or the various constriction levels, where if you're a surgeon, you can use innovative gadgets, and also if there is a small injury, you can treat them as well, the complications, if in a rare event they happen. There are certain simple therapeutic procedures which will be introduced to you today. Later on in the our panelists will show them, which you can pick up with your skills, and you can safely be performing this, like a varicose band ligation, glue injection, sclerotherapy, and many others. Of course, ERCP is one a major procedure which is a very highly skilled procedure. It is like a surgery performed through the endoscope, which of course, if you learn it properly at the later stage of your becoming an endoscopist, you can really perform many procedures to the benefit of the patients in your own setup. And here I am showing you one advantage of a surgeon being an endoscopist can perform. This was a case of hydrated cyst of the liver, whom I had done on this patient, laparoscopic hydrated cyst excision. He came back within a week with obstructive jaundice, and you can see on ERCP, I myself could retrieve the daughter cyst which had got migrated through a communicating duct into the distal bile duct. So these such patients, if you can perform endoscopy yourself, you can definitely give a single center comprehensive complete management, and you have the confidence in managing such patients. Of course, newer advances in endoscopy like third space endoscopy has come in, which is a very highly complex procedure, needs high level of training. That is possible in each one of you as endoscopists, provided you go through the process of training. And this list of such procedure which was performed in the third space is again expanding, and there are various lists, you can go through them, and they are possible. This is one such video. I don't want to waste time here, of a submucosal dissection which is being done in a sessile polyp. And likewise, endoscopic bariatric procedures are coming up, like balloon placement and endoscopic sleeve gastroplasty. There are advanced procedures which are possible through the endoscope. Likewise, as a surgeon endoscopist, you cannot be wary about the newer advances in technique of enhanced imaging technology, which can be put to use for proper diagnosis of various lesions, which will be told to you by Dr. Govindraj later part of his talk. Why still, with all these advantages, surgeons are not coming up to do endoscopy? There are several reasons which are attached to it, we all know, and there are steps which are taken by ASI. We started in the year 2022 as being a president. We started the Endoscopy Academy. Later on, Dr. Prabol, in his period as a president, he devised the term STEP and made it more systematic. And today, Praveen Survamshi, with his sincere efforts, could make it as defined it as a STEP 2.0, where Even we have got a state-of-the-art lab which has got established in our headquarters at Chennai, and that is Dr. Abhijat Sheth. Last year, November, this was inaugurated. Who is the Abhijat Sheth, being the chairman of the National Commission, National Medical Commission, and then that is the picture you can see at the national headquarters. And in conclusion, I will hand over the mic to my panelists. Before that, endoscopy is a valuable tool in the management of GI disorders. Surgeons are better in picking up skills. If surgeons do endoscopy, better planning can be done to manage patients. Innovative methods and decision-making capacities of surgeons is definitely a benefit. Surgeons are better equipped to handle a rare complication if they happen. Endoscope should become a part of the curriculum in all postgraduate training programs. ASI is doing its bit to train the surgeons of India. Thank you very much. I hand over the mic to the first panelist to take over without much ado. That is Dr. Joy Abraham from Ahmedabad. He has been a surgeon endoscopist from Excel Hospital. Please take over and give your presentation, Dr. Joy.
Thank you very much. Thank you all the ASI office bearers for conducting such a wonderful session on an important topic. Thank you, Dr. Siddesh sir and Dr. Santosh sir, for involving me with this presentation. I am very close to endoscopy because it has changed the way I have practiced GI. So today, my area of discussion is the basics in endoscopy. I presume that the audience is more of people who are planning to take up endoscopy or just doing endoscopy. So this is one of the basic things which you should be knowing about endoscopy. That is the diagnostics. So can you see my screen well?
Yeah. Make it full screen. Yeah.
Yes, it's visible.
So first and foremost, we start with the indications of upper GI scopy. The clear-cut things are dysphagia, hematemesis, and the workup of melena, severe epigastric or retrosternal pain, and then in the evaluation of iron deficiency, anemia, foreign guts, and many other indications. Contraindications: when there is a known perforation, please do not put in a scope. There is coagulopathy, the patient is in shock, or an unwilling patient. I would start with a small endoscopy video where you can see the endoscope is being passed through the esophagus. Keep the esophagus in the lumen in the center, and this is not much of a finding, but this is just a routine endoscopy because my topic is just the basics of endoscopy. So as you cross across, you can see some tongues of mucosa jutting out, which is less than 5 mm, possibly this is a short segment Barrett's. You can see the diaphragmatic hiatus from here, and definitely the Z line is way above it, so it shows that there is an element of hiatal hernia involved. Yes, you can see the mucosa here. So yes, biopsies are needed. And then we cross the hiatus, we go into the stomach, and we can see the rugae. There is some amount of fluid filled. Here the lesser curvature is on to your right and the greater curvature to your left, and then you move into the antrum, and then you can see the height, the pylorus here. Crossing the pylorus is a difficult thing early in the career. I just mention it because many times we wander around near the pylorus. So once you cross the pylorus, you are into the duodenal bulb. And while coming back, This is essentially normal. You can see the normal folds of the duodenum. The ampulla. And while coming back, then you carefully evaluate the antrum. See for any lesions. The whole idea is a deliberate attempt not to miss any important findings. So go as slow as possible, and while coming, be as meticulous as possible so that you do not miss anything. Because any lesion missed is another endoscopy not being done for a few years for the patients, and maybe a malignancy might be missed, and sometimes the patient may come with a terminal malignancy even after an endoscopy was done. So this is a very serious examination. A very meticulous and deliberate examination should be done. Here, while we are coming back, we are examining and this is the hiatus. I will definitely explain the hiatal hernia part to you as we proceed ahead. Again, here classical hiatal hernia. You can see the hiatus is literally, the fundus is literally consumed into the hiatus. So yes. So as I said, no part of the stomach should, the upper GI should be missed. These are the few areas: the upper esophagus, the GE junction, the hiatus, then the body, the antrus, pylorus, duodenal bulb, and the duodenum. This is a normal anatomy of the esophagus, where you see a nice pale pink colored mucosa, very few vessels which you can see through it. This is the squamocolumnar junction, where you can very clearly see the differentiation of the gastric mucosa and the pale pink esophageal mucosa. These are the stomach rugae, which we saw in the video. So this is a normal esophagus. Whereas when you see the same part here, the lower end of the esophagus, here you can see inflammation, some erosion. So say this is some amount of esophagitis. So this is possibly esophagitis caused by reflux esophagitis. The classification is important classification is the Los Angeles classification, which we should be very clearly aware and which we should be documenting, because results are compared. Once you do an endoscopy, the next time or the year after you do, you should be able to see how much the disease has progressed or improved. So grading is a very important. So that is the reason standardization is important, and you need to follow certain classification. The LA classification is one of those, where you have the grade A, grade B, grade C, and grade D mucosas. Here is an endoscopic picture of the erosions which are extending into the esophagus. This is more than 5 mm in length. You can see this is the length. If you can see my arrow, this is more than 5 mm. However, the bridges across the mucosal folds, they have not been crossed. If this was less than 5, this would have been grade A. This is more than 5, so this is grade B. And if you can see in this picture, these are the erosions extending more than 5 mm into the esophagus. And here the top mucosa is, the mucosal break is continuous across the two rugae, or the top of the mucosal folds, but it is less than 75% of the circumference being involved. So this is a grade C LA classification. Then this is a sort of grade D, where a significant amount of the lower esophagus is involved. This is another picture of the another pathology of the GE junction, where you can see tongues of mucosa, red colored mucosa extending, angry red color mucosa extending into the esophagus. It is classically Barrett's. Wouldn't like to delve too much into the details of Barrett's, because this is just a primer, and we need to just brush across very important things. This is, yes, you can see a direct view into the stomach, where you can see the squamocolumnar junction. And you can see this is the diaphragmatic hiatus, which is way below. So this is a classical hiatus hernia. In hiatus hernia, again, very important if you do endoscopy that you should know the classification. And the standard classification which we follow is usually the Hills classification, which is grade 1 to grade 4. These are the different grades. You can see in the grade 1, there is slight loss of the mucosal fold. It is not as nice a fold as it should be. I can show you in this. This is a nice fold which is formed by a wrap. But here the fold is not as well defined. Here you can see the fold, but there is rapid opening and closing. And if you see the three-dimensional view of the stomach and the esophagus, this is the stomach, this is the scope viewing the retroflexion view. As the stages increased, more and more of the esophagus is shortening and is being pulled towards the fundus. Here, the esophageal opening is very less distance from the hiatus, and you can see this is the fundus and this is the G junction. And here, this is a sliding hernia where the entire stomach has crossed the diaphragmatic hiatus and gone into the thorax. This is grade 4. Grade 3 and grade 4 are classical with symptomatic needs surgery. This is another picture of a prolapsing gastropathy where in the esophagus you can see the gastric mucosa prolapsing due to retching. Another important thing which you would like to see is because post laparoscopic fundoplication, we would like to see our wraps, how well the patient is doing. In case he's not doing well, then maybe you need to examine. Here, this is how a nice tight wrap looks like. It is very well wrapped around the endoscope. And here you can see that the wrap is a problem because it is wrapped around the stomach. And there is a significant gap here. Another important pathology when you do endoscopy is to identify varices, not to miss varices, to grade varices, prognosticate varices, and treat varices, and also definitely know the etiology behind. These are esophageal varices. This is in the esophagus where you can see tortuous dilatations of the varices. Here it is blue in color, which is a bad sign. Again, for esophageal varices, you need to know the classifications. One of the classifications which we follow is the Japanese classification of esophageal varices, which are essentially simple. The color of the varix is noted. If it is blue in color, it's not a good sign. White varices have less tendency to bleed. The red color signs, that is the red whale marking, the cherry red spot, the hematoma, and the series going downwards, the complexity and the possibility of bleed increases. Another very important form is the form of the point of the classification is the form of the classification. F1 has straight varices. In this, you can see these are tortuous varices. So yes, they are not F1. So this could be F2. Here you can see that they are not completely occupying more than 1/3 of the lumen, maybe less than 1/3. So these are F2 coil-shaped lesions. F3 is more than 1/3 of the lumen is occupied. And then on the basis of location, if it is in the inferior, medial, or superior esophagus, and E is if there is esophagitis involved. F2 and F3 have a tendency to bleed more. So it should be banding should be done. The patient should be prognosticated of the possibilities of rebleed. That is an important part of it. Then comes to some other non-variceal bleeds where ulcer bleeds are there. Here you can see a nice gastric ulcer. Endoscopically, you should be able to know the difference between an erosion and an ulcer. Erosion is superficial, ulcer is deep. Ulcer, the base is usually you can see the submucosal vessels or the muscularis. Again, this is a very famous classification of forest for non-variceal bleeds, which is based on the basis of active bleeding. If there is a spurt going on, then there is a possibility that there would be a bleed within 100% possibility that there would be a bleed within the next 72 hours. Surgery mentioned here because this is a very old slide, but now I think surgery is totally obsolete and it is endoscopic surgery. And that is precisely the reason this talk is being organized by the Association of Surgeons of India, to underline the fact that a lot of procedures are for the benefit of the patient being done endoscopically, and hence surgeons should be taking up endoscopically, because this was what we used to do a few decades back, and now we are the people who are like very well trained and qualified and skilled to do these things. So take up more and more endoscopy and keep doing it. Then 1B is the oozing hemorrhage, which has an 80% of rebleed. Then visible grade 2A, B, and C are visible vessels, an adherent clot, or a flat pigmented spot, in the decreasing tendency of rebleed and possibilities of surgeries and less mortality. And the basic one is a clean ulcer base, which has very less chance of rebleed. Another important diagnosis as surgeons we should be making, because Dr. Siddesh had shown in his slide the importance of knowing the site of malignancies, because especially in GE junction, you need to know where exactly, because you really cannot rely on an image done by an endoscopy by someone else. It makes a huge difference. If you see, it forms a mind map and you can do the surgery much well. I can tell it from my experience that it makes a huge difference. It adds just another dimension to your skill, and moreover, it is a beautiful skill which you will never forget, and you will in fact become very passionate about these things. Again, a retroflexion view seen from the stomach. These are the basic images and diagnostic, which is I would not take much of the time. And in short, my message would be to take up endoscopy, surgeons to become more skilled with surgery. And that's all. Thank you very much, sir. I would like to.
Thank you, Dr. Joy. That was very nice presentation, crisp, and very importantly, as I requested, you have put forward very nicely the classifications, which may help also the young endoscopies. I would next I would request Dr. Govindaraju would come up and tell us about the newer advances in imaging technology, which can help us in interpreting some of the complex lesions much better way, and the newer advances and use of artificial intelligence as well. Dr. Govindaraju.
Full screen. Yeah. Thank you, sir. And good evening to the President, our Secretary, the past President, and the President-elect, and our advisor, and today's moderator, and my wishes to all my fellow speakers today. And as you all know, the endoscopy is becoming more and more a state-of-art diagnostic tool. And as everybody has been telling, endoscopy is now become a part of the surgeon's armamentarium. And without endoscopy, it becomes very difficult in certain places where you have a salvage which can be done without surgery. So to introduce about what I'm going to talk today, there have been advances in image enhancement for almost 3 to 4 decades, and which was done by using a method called the chromoendoscopy. The initial chromoendoscopy was done using dyes. Basically, it was indigo carmine or acetic acid, which has been used by most of us for almost 2 decades initially. And then the newer techniques or the newer image enhanced endoscopy started, and in which we call the image enhanced classified is either it's a dye-based endoscopy, or it is a dye-based endoscopy, or it is going to be
Govindraj?
Yeah, 1 minute. Yeah, it's going to be a dye-based endoscopy, or it can be an electronic chromoendoscopy. So what we call it as electronic chromoendoscopy is nothing but NBI with the eye scan or FICE, BLI or linked color imaging. These are the various companies which have named it in different ways. So when you get into the basic of electronic chromoendoscopy, everybody knows what we call the narrowband imaging or the NBI. This narrowband imaging was introduced in 2005, and this was the time when I met this Dr. Kano. So Dr. Sano was the one who introduced this narrowband imaging when I was in training, and this was the basis of this chromoendoscopy. And this is by a company called Olympus. There are different companies, so I'm not, basic disclaimer is I'm not with any other company. I just want to give a brief of what each company names and what is their strength and what is their portfolio, which is not, they don't have. In this basic principle, the depth of light penetration into the tissue is directly proportional to the wavelength. So narrowband blue wavelength, which is around 450 nanometers, penetrate only the superficial light. Then comes the green light, which penetrates to the intermediate tissue, and then comes the red light, which penetrates to the depth. So if you look at the virtual chromoendoscopy, it is nothing but an electronic enhancement without dyes. If you look at the image here down at the bottom, where you can see the blue light only comes the superficial layer, then the green light comes up to the capillary layer, then below this capillary layer, the red light goes in. This is what is called the narrowband imaging, which is by the Olympus company. The advantages or the applications are adenoma. It is used for differentiation between adenoma and hyperplastic differentiation. And it is very useful in margin assessment when you do an EMR or an EST, and particularly useful when you have an sessile serrated lesions. And it definitely improves the texture, the brightness, the color of the lesion, and it is very useful in neoplasma, very early detection. So there is another company called the Pentax, which uses a similar technology but name it in a different way called the iScan. Here they have got three main characters. One is called the surface enhancement, second is called the contrast enhancement, third one is called the tone enhancement. So surface enhancement enhances the light-dark contrast on the basis of the illumination. The tone enhancement divides the image obtained using a normal white light into components and then converting them into new images. These are the two important things which you have to understand when you do about the eye scan. Then comes another company called the Fujifilm or the Fujinon earlier, where they call it as a flexible Fujinon intestinal chromoendoscopy. Here, the proprietary post-processing digital imaging was developed by Fujifilm, which uses a wide range of spectral combination and also known as multiband or optimal imaging, which can produce up to 60 types of spectral images can be seen in this. They have also come out with a recent thing called the BLI or called the blue light imaging, and LCI or called the linked color imaging. This is type of an equipment which is based on an image enhanced endoscopy, which focuses on the characteristic of the short wavelength absorption of the hemoglobin combined with the specific white light spectral colors. It results in accurate contrast imaging. It also increases the efficacy for diagnosing early gastric cancer. So linked color imaging is very useful in early gastric cancers, and blue light imaging is much useful in esophageal malignancies. So blue light is nothing but a blue-green color information which produces a red color enhancement. LCI uses information of all three colors, red, blue, and green. Unlike the white light imaging, the captured image output has color enhancement in its own color range. So it has red changes, becomes vivid red, something like that. It happens to all the three colors. So in this way, the intense blue light enhances the microvasculature in blue light imaging, and it is excellent for optical biopsy. What do you mean by optical biopsy? You can use a blue light imaging and then you do a targeted biopsy, that is called an optical biopsy. Linked color imaging, it increases the color and contrast. It is best for polyp detection when you do for either a colonic polyp or an upper GI polyp, and it also enhances the red-white differences also. And here comes a classification which is called the IPCL, which is nothing but an intrapapillary capillary loop calcification. And these are basically type A, type B, B1, B2, and B3. These are basically tiny capillary roots present in the esophageal squamous epithelium, they are best visualized using the narrowband imaging with magnification. So changes in this IPCL pattern help to detect dysplasia, early esophageal squamous cell carcinoma, and also helps to assess the depth of invasion. And another classification which is very useful here is classification of Barrett's. Here I want you to give importance only to the fourth and the fifth paragraph. The fourth paragraph here is the Barrett's International NBI group. It's called the Bing group, where you have the modality is the NBI. Then in normal, how does it look? It looks with a mucosal pattern or circular or ridge or villus tubular. The vascular pattern, the blood vessels are situated regular along the mucosal ridges. And when it comes to intestinal metaplasia, it is the same. And when it comes to dysplasia in the Bing classification, the mucosal pattern is completely absent. The vascular pattern is focally or diffusely disturbed. And so the overall sensitivity is 80%, overall specificity is 88%, and accuracy is 85%. If we go into the fourth one, which is nothing but the BLI classification, it is also called the Blink classification, where again for the normal is the mucosal pits are circular and the vessels are non-dilated and regular. In the dysplasia, you have the mucosal pits are amorphous or focal loss of architecture is seen. The vessels are dilated, tortuous in type with a non-cryptal distribution is seen. This is one of the two classification which has been widely used for Barrett's using an image enhancement. So advantages are it overcomes the drawbacks associated with the regular staining method which was used earlier. The diagnostic capability is almost all comparable with the regular chromoendoscopy. In combination with magnification endoscopy, it improves the clarity of visual assessment. So in colonic polyps, early gastric malignancies, it is very, very useful and improves the adenoma detection rate. It is the ADR which is useful in this both in upper GI and in lower GI. It's very useful in characterizing the polyp and assessing the completeness after completing an EMR or an ESD, and it is very useful in IBD surveillance. What is going to be the future of this image enhancement is it improves the efficacy in diagnosis and treatment of early esophageal and gastric malignancies. It is very useful in assessment of pre-malignant lesions, developing a useful training module. It is optimization of either FICE or NBI or iScan is to adapt imaging to the location and structure of the lesion, establishing consensus in application, image processing, and image analysis on multicentral trials, develops disease-specific classification system, and completely it is very useful in particularly in community-based endoscopy. Then comes the latest in endoscopy, what is called the artificial intelligence in upper GI endoscopy and lower GI endoscopy, how it is going to be useful. Just to give a glimpse, because it's a very big topic, I'll give a glimpse on
keep
what
it
is
short. Keep it short.
Yeah, AI uses deep learning and CNN, that's convolutional neural network. And the key techniques are CAD, that is computer assisted detection, computer assisted diagnosis, image enhanced endoscopy plus AI, where again the same things comes which have been already discussed. How AI is created, you have to have these broad four classification you have to understand. Data collection, data preparation, learning style, and finally it is how it is processed. These are the companies which have their own AI. It is from Olympus, it is called the EndoBrain. From Fuji, it is called the CAD-AI. From Pentex, it is called the Discovery AI. So various companies have their own artificial intelligence tool for endoscopy. So these are the various systems which are available nowadays to compare with the other systems. I will just tell you a hint about how this endoscopic artificial intelligence works. You look at this image, you will have a squarish thing that is called the annotation. So you don't miss a polyp there, this annotation comes. Another important thing is there is always a detection sound. Whenever there is a polyp, the detection sound comes, so it doesn't allow you to miss a polyp. And this detection box doesn't allow you to miss a polyp. Then the visual assist circle comes. If this visual assist circle comes in a green color, it says that it is a benign polyp. If it comes in yellow color, it says that it could be a benign, it could be a malignant polyp. So in this way, If you look at the video here, this is another lesion where this annotation comes. It is telling you there is a polyp there. If you do a fast endoscopy or a colonoscopy, you might miss this polyp. So here you can see in the lower corner, there is a green image appearing. It says that it's a benign polyp. It can be an adenoma, hyperplastic adenoma, or it can be an hyperplastic polyp. So in this way, it is helpful. It is 85 to 92% accurate in saying whether it is benign or malignant. So application of this AI is detection of Barrett's dysplasia, detection of early squamous carcinoma, application particularly in the stomach is early gastric cancer detection, and particularly in H. pylori induced gastritis predictions. So the advantages are it improves the detection rate, reduces the miss rates, and real-time assistance. Of course, limitations are there. There can be false positives, and this AI tool currently is a little bit expensive, and it is limited availability is there. So what is the future of this AI? Integration can be done with robotic endoscopy. Better real-time histological prediction can be done, and so it will be definitely useful. We use it for community-based endoscopy. When you do a community-based screening, we use an AI for detection of early malignant lesion. So conclusion is AI transform diagnostic accuracy and standardization in upper GI endoscopy. Thank you very much for your patient listening. Thank you very much.
Thank you, Dr. Govindraj. That was an excellent presentation and an introduction to AI as well. Let us come back to you for some more clarifications later in the time. We'll go to the next topic, having dealt with how we basics of doing a endoscopic assessment of the lesions. We go to what the same tool can be used to treat the lesions. So with that brief introduction to this facet of endoscopy, I would request Dr. Bhavneet Bala to come in and educate us. Thank you.
Dr. Balla, sir, your voice is muted. Yes.
Is my presentation visible, sir? Are my slides visible?
Not yet.
Okay, I'll just share them 1 second.
Only the screen is seen. So what you do? Yes, it has come up. Make it full screen. Go ahead.
Yes, sir.
Dr. Bala, make it brief so that we can have more time for discussion later. Thank you.
Yes, sir. So, a very good evening to everyone. And before I start my talk, I would like to thank the entire leadership, President, Vice President, and the entire leadership of ASI for inviting me to this very timely and relevant academic webinar on the role of upper GI endoscopy. So, I have been assigned the topic of the therapeutic endoscopy, and over the next 10 to 12 minutes, I'll be trying to talk about the role and the relevance of therapeutic GI endoscopy in modern surgical practice. So my job has actually been made a little bit easier by my previous speakers. So I'll start my presentation by showing a very interesting slide and some interesting data. Now this slide and this graphs here basically represent the total surgical work volume and the GI work volume over a period of 100 years. So the total surgical work volume, all the cases were done by all the surgeons over a period of 100 years, they were plotted here. And the blue line represents the surgical work volume, and the green line here represents the work volume or the number of cases being done by GI endoscopists. And it is very obvious that for the first 7 to 8 decades, almost up to late 1980s, we see that the surgical work volume is at around the level of 100 and the GI work volume is somewhere around 20 or 25. But if you look carefully, you will observe that the graphs are now showing some reverse trends here. Somewhere around 1980s onwards, the graph for the surgical work volume has started to come down. But this is very difficult and surprising to actually explain how does this happen. The overall population, the number of surgeons, hospitals, everything is increasing. How do we explain that the number of surgical cases being done by the surgeons is coming down? Well, the answer to this mystery is actually in the green line, which is representing the work volume now being done by the GI endoscopists. And you can see that by the around the time that the blue line has started to come down, the green line, which represents the gastroenterology work volume, has started to go up. So there is a very simple explanation to this, that a slow and steady transition is happening from the scalpel to the scope. And therapeutic endoscopy has now actually become just another way of treating a disease which requires a surgical intervention. I think the best example for this would be a ERCP. And, conventionally, CBD is supposed to be the domain of the surgeons. Now, whether a patient comes with any kind of a biliary obstructive disease or any biliary leak, the patient was managed by surgeons conventionally. But as we all know, this is no longer true. Any patient coming to even a surgeon with such problems is now actually referred to an endoscopist who would be doing a ERCP. So this is something, a very classical example where an endoscopic therapeutic procedure has overtaken the surgical procedure for particular diseases. And today, with the advent of advanced scopes like a cholangioscope and advanced modalities like lithotripsy, there is probably no such case of either obstructive disease because of stones or stricture or biliary leaks which cannot be managed by ERCP. So simply put, the role of surgery has drastically been reduced as far as the interventions into the hepatobiliary tree is concerned. Let me give you a very simple example. ERCP is a very advanced technique. Let's talk about a very simple procedure such as a feeding gastrostomy. Whenever we are looking for some prolonged or long-term enteral nutrition, we have an option of doing a feeding gastrostomy or a feeding gastrostomy. However, on the endoscopy side, we have an even better method in the form of a percutaneous endoscopic gastrostomy. Now, this method, as compared to the surgical option, is even less invasive. It requires shorter time, shorter hospital stay, cost less, and the recovery is faster. You can actually start the patient on feeding through this PEG tube within the 4 hours of the procedure. So simply put, again, endoscopic procedure which is proving to be better than a surgical option for a particular indication. And this is just not limited to ERCPs or PEG procedures. If you look at the upper GI tract, you look at the hepatobiliary interventions, you look at the small bowel, you look at colon. Therapeutic endoscopy is actually turning many surgical diseases into endoscopic diseases. Now, everybody is aware of the advent of endoscopic ultrasound, and this is proving to be a game changer actually. It is already an established modality for diagnosis and staging of GI malignancies, but it is also a very robust platform for performing therapeutic procedures. A very simple example to convey the message. Supposing a patient has a malignant biliary obstruction and is no longer salvageable, or we are just looking for some sort of a palliative procedure to be done. A very straightforward example would have been to do a ERCP and put in a stent. But what if that ERCP failed? Now, does that mean that we do not have any other endoscopic option left? Well, that's not true. We can still go ahead and do a ES guided biliary bypass procedure such as hepatogastroscopy, thus sparing the patient the need for a PTBD or a surgical bypass. This can drastically improve as well as preserve the mobility, the dignity, and the quality of the life of this patient. And it's not about just doing a biliary drainage. Just look at this list of the procedures. Now, these are basically all surgical procedures. We could be doing a cystogastrostomy for a pseudopancreatic cyst, or we could be doing a drainage of a walled-off necrosis, a gastrojejunostomy, a choledochoduodenoscopy, a edge procedure, which is again a kind of a ERCP, which we do in patients with altered surgical anatomy. These are all basically surgical procedures, but now are being routinely done under the guidance of a echo endoscope or endoscopic ultrasound. Just a simple example, a different way of doing the same surgery. This is an example of a gastrojejunostomy which is being done under the guidance of EUS. The approach is slightly different. Here, instead of taking sutures and all, we are using these lumen opposing metallic stents. Something similar going on here. This is a case of a choledochoduodenostomy being done after a non-negotiable papilla. Then earlier it was also mentioned about the third space endoscopic procedures. Now the story of third space started with the POEM procedure, which is actually now replaced Heller's cardiomyotomy to a large extent. We have a better option in the form of an endoscopic myotomy or the POEM procedure as a treatment option for treating eclasia. Now, this is actually slowly becoming almost the gold standard of treatment for all patients of eclasia. We are not only restricting ourselves to treating eclasias. Now we are applying these third space endoscopic procedures for treating gastroparesis, for treating a Zenker's diverticulum, and as we are all aware, for all early GI malignancies, superficial lesions, endoscopic submucosal dissection has actually become the go-to procedure. Now these are much better procedures, less invasive and more precise as compared to their counterpart surgical options. Now, another way in which endoscopy is becoming relevant for surgeons is in the form of these hybrid procedures. Now, today, interventional endoscopists can, do a very good local excision of the tumors with techniques such as ESD or EFDRs. But GI surgeon can also now offer a very minimally invasive option and do a precise excision. But in this competitive race between an endoscopist and a minimal access surgeon, each of these two approaches have their own strong points and weaknesses also. So slowly, a newer laparoscopic and endoscopic cooperative approach, or what we call as a hybrid surgery, has emerged, which basically gives you the best of both worlds. Anybody who is practicing hybrid surgical procedures will realize and will gain from the benefits of laparoscopy, such as faster and more precise and wider resections. And not only limited to the resections, but you can do adjunct procedures like lymph node biopsies or lymph node clearance. At the same time, the endoscope during the same procedure will give you a magnified view, will tell you a more precise demarcation of the lesion margins, and will also give you an option of retrieving that specimen which you have excised through natural orifices. It's not about competition, it is rather about cooperation. So you can do hybrid surgical procedures, which could primarily be a laparoscopic surgery, but under the guidance or assistance of an endoscope, or vice versa. It could be primarily an endoscopic surgery, but under the watchful eye of a laparoscope, or it could be a combined lap endoscopic resection. So hybrid approaches now enable very precise localization as well as resection of the lesions without compromising upon the oncological principles. We are all familiar about the NOTES approach to minimal access surgery. And for more than a decade and a half, we have been trying to do NOTES procedures which are truly incisionless or scarless. But even today, NOTES has not taken up in a big way. This is because of the limitation of the systems which we are using. We have been trying to do NOTES using flexible endoscopic systems or rigid minimal access systems via laparoscopy or robotic surgery. But both of these modalities, they have their own limitations. But as of today, these limitations are now being addressed with the advent of flexible robotic surgical systems. This is basically a fusion and a marriage between flexible endoscopy and minimal access surgery. And this has greatly improved our accessibility and feasibility of doing nodes or endoluminal surgeries. So slowly a paradigm shift is also happening in the way we do surgeries, and we are doing completely true nodes or scarless surgeries. It basically refers to going through the natural orifices and doing the procedures either within the lumen or through the lumen, but with the use of a flexible operating robotic system, thus making the surgery truly nodes or truly scarless or incisionless. So the advantage here is these robotic flexible endoscopic systems give us excellent degrees of movement and also provide the triangulation, which is otherwise significantly lacking in our conventional endoscopy. So the approach could be either transoral procedures, transrectal procedures, or even transvaginal procedures. And we are talking about doing procedures such as a ESD or a myotomy, even a gastric fundoplication. Or why restrict ourselves only to the endoluminal procedures? We can actually go transluminal and do a transluminal cholecystectomy or appendicectomy. This is not something science fiction which I'm talking about. The systems are already there. In fact, this is one of the first systems which got its FDA clearance way back in 2015 for colorectal procedures also. So this is the flex system from Med Robotics. And just to give you an idea to our viewers how this works, this is basically a flexible robotic system which has this single port through which the surgeon who is actually sitting at the console is going to control and and advance this over tube, and then the flexible endoscope itself is advanced. Now, because of the flexibility and the durability of the system, this can be taken through the natural orifices per orally into the esophagus, and you reach the target of surgery. And then alongside this overtube, alongside the flexible endoscope, comes these flexible robotic instruments also, and thus giving you a wonderful view and a wonderful triangulation so that you can do. Just a demo video demonstrating that a full thickness perforation, a bowel defect is being closed by perforation endoluminally. There are lots of other systems which I will probably skip because of want of time. And as I was saying earlier, why restrict ourselves only to endoluminal procedures? Slowly and slowly, endoscopists now have the capability to go transluminally or outside the hollow viscous, and we are talking about doing procedures such as a transgastric or even a transrectal cholecystectomy here. So the next revolution in surgery may not happen through the abdominal wall, but rather through the GI lumen. So we are all familiar about the importance of bariatric surgeries in today's. On a parallel world, all these endobariatric and metabolic therapies have also evolved, and they are giving results which are almost comparable to those of bariatric surgeries on a long-term basis. So we have endobariatric procedures starting from a simple intragastric balloon placement to doing a procedure like a endoscopic sleeve gastroplasty or doing the gastric plication using a pose or an endomina device. One of the biggest limitation of conventional flexible endoscopy was that we could not take full thickness bites and do a suture. That problem is now a thing of the past. We have devices such as this overstitch device, which allows you to do or take full thickness bites and do a complete closure of the defect as if you are doing used for outlet retractions after a gastric bypass, or it is used for fixing the stents, or even for closing post-operative leaks and fistulas after a surgery. This is a very interesting graph which emphasizes the role of endoscopy in the management of surgical complications. And whether it is upper GI, colorectal, hepatobiliary, or bariatric subspecialty, we find that endoscopy is now coming to the rescue of surgeons in managing the surgical complications. Just to give you some examples, any kind of obstruction anywhere in the GI tract, it could be in the upper, it could be in the colon, or it could be even be in the CBD, can now be managed by putting these stents endoscopically. Any kind of a GI bleed again can be managed, and there are multiple options in which we can manage these bleeds. You can have a patient who is bleeding from a gastric ulcer, or you could have a
time. We just finish it.
Just finishing it, sir. This is the last slide. Couple of more slides. That's it.
Thank you.
So we have all these options here to manage GI bleeds. Similarly, we have lots of options here in managing the post-operative leaks and fistulas. So today we actually as surgeons stand at crossroads. Endoscope is no longer just a diagnostic tool. It has actually become a powerful surgical instrument which is capable of performing these complex surgical interventions but without giving a single incision. So therapeutic endoscopy is redefining how surgeons are actually operating now. And if surgeons do not embrace this evolution, we may actually end up just becoming operators of the last resort rather than the leaders of innovation, which we have always been. So the future of GI surgery will not be defined by bigger incisions or bigger instruments, rather by endoluminal therapies and hybrid procedures. So the future surgeon must not only master the scalpel, but also the scope. So I will end my talk here by emphasizing the point that in today's times, every surgeon should strive to be a surgeon as well as an endoscopist. The future is hybrid for all of us. Thank you.
you, Dr. Balla. I think we are running short of time, but the message is very clear. Not that everyone need to be proficient enough to perform all these procedures, but the what is there in future coming, we got to know, and we cannot be wary. That is a message. And early you start doing endoscopy is better. So we are here to handhold you. And let us come to the last topic, last speaker of today's panel, Dr. Satyapriya Desarkar. And he's a senior surgeon from Calcutta. Sir, please come up. What can be done by you? Probably some of the videos he's going to show you.
Good evening, sir. Extreme regards and gratitude to the present President, Vice President, President-elect, and the whole dignitaries, and especially to Professor Siddesh and Professor Santosh for allowing me to come in front of the elite audience of ASI members. So what I am going to do, Jai has shown you the basics. Govindraj has shown you the very important changes and development in how you look the images, and Bhavneet has really shown you the limitation, all the limits of endoscopy, where we can reach and where we are reaching at actually. So let me move on with this. One second. So that's me doing my endoscopy in my room with my team. And we are going in the slide. Yes. Yes. So that's my best wishes from Kolkata, the two Howrah bridges and the Birla Planetarium, near which my endoscopy shoot is there. So polyps are very, very important and going with the very commonest thing, and the first thing you should encounter when you are in the learning curve and going for the diagnostic endoscopies. Most important are the adenomatous polyps and non-adenomatous polyps, like the inflammatory polyps, juvenile polyps, or submucous masses. These are important because of before that polyp, we have not many classification, but now we should know the commonest things, that is the Paris classification, where we have the pedunculated, we have the elevated or sessile, and we have the excavated polypoidal lesions. And why polyps are so important? Because of adenoma to carcinoma sequence. We all know if you have to cut down, India has a very big number of colonic carcinoma, and if you can break the sequence of adenoma to carcinoma, then really the patient load will be better. So the progression from adenoma to carcinoma is an accepted model of malignant transformation. That's why we cut that one before it changes from dysplasia and to the malignancy. So these are the instruments we use: the monopolar argon plasma coagulator, the heater probe, the bipolar probe, monopolar polypectomy snare, monopolar hot biopsy forceps, and very rarely laser. This is how the patient size, and we put the pad below the patient, and then the whole circuit is completed through which the energy goes. And these are the accessories you see, very important. Polyp snare of different sizes and shapes. For want of time, we are not going into details. And injection of the needles with the epinephrine, normal saline, and methylene blue. We always will show you the picture how you take up saline lift, as we call. We inject this solution into the submucous layer to make it safer, to make it less vascular, and definitely after the excision of the polyp, the next most important thing is retrieval. And for me, I feel the Roth basket is the most dependable one, and endoclip sometimes you need to prevent the bleeding or to close the white base of the polyp, especially of the submucous dissection. Polyps, when there are more than 2 centimeters, be careful. They have increased bleeding risk and the increased risk of perforation, increased risk of dissection, increased time of dissection. You have to go maybe part by part, piece by piece, Also, if you go SMR, also it needs lots of time. Polyps covering more than 1/3 of circumference of colon are more difficult to safely remove endoscopically. So be always careful about your limitation, your training, your assistant, your instruments, where you are working. But the polypectomy positioning is very, very important. You know, all the accessories are coming towards the 5 o'clock or 7 o'clock. So polyp base should be placed in the 5 to 6 o'clock position if possible. Change the patient position if polyp location makes position difficult. Keep the polyp at a short distance from the tip of the endoscope, and ensure a safe tissue capture by moving the snare catheter back and forth, and there should be free movement and the underlying colonic wall. Otherwise, you may have taken the deeper layers. You have to take only the mucosa and submucosa. If concerned about the muscularis propria is entrapped, loosen the snare and go little up. After encircling, aim to keep the polyp in the center of the lumen to limit the thermal damage, lateral damage to the adjacent tissue. And the polypectomy recommendation is: one, immediately dissect the small polyps identified during insertion. Do not defer until withdrawal phase. Some of the time you may miss it. Consider the cold forceps resection for polyp less than 5 millimeter in diameter. Consider hot snare dissection, that means using the energy devices when there is more than 10 millimeter in diameter. Check the functionality and setting of electrosurgical unit before application by yourself. Don't depend on your assistant. Make snare handle shaft to show the tip of the snare at the tip of the catheter, means you should not close it too tight. So we are planning for a hot biopsy, and ultimately you cut it with a snare and it becomes a cold polypectomy and can lead to very bad type of bleeding. Then orient the polyp at the light lower, that is 5 o'clock position before resection, one of the best position, or 7 o'clock when polypectomy snare is open. Carefully position the tip of the plastic catheter and pull the polyp, and then close the snare towards that point. So you can fix up a particular distinct point of the polyp where you want to resect, not leaving any stump, not taking extra one. After closing snare around the polyp, deflect the scope tip towards the lumen to ensure that no snaring on the adjacent wall. So take it to the lumen and then check the distance between the snare handle mark and position after snaring the polyp. That gap should be around 3 millimeter, not closer than that. Then during the cautery application, tent the snare polyp into the lumen. Before initiating the further closure of the activated snare, wait for the coagulation visible blanching to occur. Deliver the cautery steadily until the polyp resected snare. Wait for the coagulation visible as blanching, because don't cut it with the sharp and cutting current, and generally continue the cautery until the resection is completed. And this poor prognostic feature of some malignant polyps are incomplete endoscopic resection. It may lead to bleeding, it may lead to stump recurrence, poorly differentiated carcinoma, and within 2 millimeter of the polypectomy margin. So be careful. That's why NBI helps in. Sometimes you can see the pit pattern difficulty, the abnormality, even beyond 1 to 2 centimeter of the base of the polyp, to include that one. Venous or lymphatic invasion, if it is there, sessile polyp, cancer larger than 1/2 of the polyp volume, and large polyp more than 2 centimeter. And submucous, what we do to prevent this one: submucous epinephrine injection, the 1 in 1 lakh dilution I use with saline, a normal saline, and methylene blue. Endoloop we can put, it was a very big one. I remember 2 of the conferences I was in the live, and when I was checking the patient 7 days back, there were 2 huge polyp in the cecum near ascending colon. I put a endoloop, and after 2 weeks, when I was actually doing much reduced in size, vascularity is much reduced. So that's a fantastic thing. Clip placement after polypectomy. Sometimes don't put the clip before. You can put the endoloop before, but clip only after the thing is done. This is one point you should remember, that post-polypectomy coagulation syndrome, or the transmural burn syndrome, is development of abdominal pain, fever, leukocytosis, peritoneal inflammation, but in the absence of any frank perforation. Importance is, these cases clinically you may feel that there is a perforation, but all these cases there is actually no perforation, as you can see in the CT scan, and then you can treat all these patients by conservative treatment. If perforation occurred, immediate perforation secondary to mechanical stress, barotrauma as a complication of electrosurgery, delayed perforation minutes later due to insufflation causing pressure on the polypectomy site, hours or days later by the necrotic piece of tissue, and sloughs of due to the coagulation necrosis. All are very, very uncommon. Be very careful so it doesn't happen. In management of bleeding, you can put the endoclip after polypectomy, endoloop before or after polypectomy, injection of epinephrine to cause tamponade, then just cauterize that point, and care with the volume of epinephrine in the cecum, where only that pedia is very thin, so it can be ischemia in the rectum. The vascular supply could lead to a rapid absorption and even cardiac side effect. So these are the two places you are careful. This is the submucous saline cushion. You can see first injection should be given distal to the polyp. That's important so that the polyp comes towards you, not vanishes there. So you can see how nice it has gone up and below. And then when you cut, you see at the base there is blue mark so that you can make out that you have not gone beyond the submucosa. This is one video I'm going to show you. Going a little fast so that we don't have much time already left. So you see how we can see the polyp there. Yes, that's the polyp. We can see there, polyp, it's a polyp with a pedicle. Then now you can see nicely the polyp with the pit pattern, irregularity and the tip, and there is a nice pedicle is there. Then what I do, we always put some injection into the base of the pedicle. We fix up the place, see it is in the 6 o'clock or 7 o'clock position, and see the needle is coming and we are putting the needle, usually the 23 or 25 size, that into the base of this one, and see how we are pushing the saline lift. That's the saline lift we do that makes it, the tamponade and the constriction makes it less vulnerable for going for any perforation. Then we pass the garland, the snare above this one, and see, this is the snare has come out. This is a hexagonal snare. This we have used there. Yes, many times due to wash this problem happens, but this is a part of that. You see how we can garland, and then slowly we are putting the plastic point at the base of the polyp, and then we are giving the tightening it, not too much so that we are not going to do the hot biopsy. See, we have tented it into the lumen so that it doesn't go to the other side and lateral effect doesn't happen. So that was there. This is another small one. We are going to do banding in these patients because Dr. Shiddesh told that we to show the polypectomy banding and the APC, very small videos. You can see we are going inside. This is a case of CLD where they have already there was bleeding and it's not prophylactic. Secondary, see, you go just the margin of the GE junction, then you suck it till it blasts completely. We have already given one band over that one. We are going to the opposite wall and going in a spiral manner. See, again, we are having a beautiful suck. So it is sucked in, and then only we put this one, the band over the second one. And then we again slowly, every time we are coming up, we are showing how the hand, you see the handle, and you see that where I am pushing, how the band is kept and band reel is there. See, yes, that's how we are putting the, see, we have made that one, and the band is at the base of the polyp, and you can see nicely. Again, we are going spirally up. That I just want to show, that we are going spirally up and giving one after another. That one is the last one. And that another one, this is the case of gave, serious gave. You can see very nicely. Only last week I did this one after Professor Siddesh told me that if you can get these three procedure, you show it. So it's a wide grave, and these patients had 2 years back we did. Before that, he had 40 units of blood transfusion in 2 years. So it was going on and on. We are planning for even gastrectomy. Then they came to us and we did the APC, argon plasma coagulation is a beautiful machine where argon gas is actually turned into that argon plasma coagulation, and we are passing the probe and we are not even touching C. We're starting from the distal part. That is the probe which is going, and now we are applying. Yes, we're applying the AP Pargan from a little distant, a few millimeter, 1 millimeter, 2 millimeter. We are serially going one by one to the different parts. Is a huge one. All around this one, it was going on. We are showing the finger is little displaced, and that always we go on with all these things. See, this is how we are going. This is a bigger one. So we are going all around, and each one by one, we are doing the APC, argon plasma coagulation of this gastric antral vascular ectasia. The patient really was 2 years back we did, and then they are really satisfied. They came back, it again reappeared. So we are again going on with this thing. So all the places we have gone, and this is the ultimately final report I have given there, where you can see the very nicely the almost all the gaps we have managed. So that's a very important thing. Conclusion is endoscopic polypectomy is a very useful, important therapeutic procedure, and is a very common one. Actually, when your test is being done, how many adenoma detection rate, how many you detect. If requires good quality video endoscope, essential accessories, well-trained endoscopies and staff should be done in a setup where treatment for complication like bleeding or perforation is available. Don't do in such places, because complication always is a part of your performance, but never be a thorough assessment of the polyp and plan the procedure, estimate the endoscopic resectability according to your team, your instrument, and your expertise. Do not start if you are not sure that you can complete the procedure. Send it to someone else who is better than this. And really what I feel with this guidance and definitely the organization of Professor Siddesh and Professor Santosh and all the dignitaries, what we all four panelists are doing, we are passing whatever we have learned over decades, that light to light up your dreams. And that's why we are also enlightening your lights, your candles there. And ultimately, you have a fantastic lightning in your horizon. Thank you.
Thank you, sir. Thank you. So I would just, without wasting time, because we have overshotting time, I'm sure Santosh should be after me to close the event. But we will be not doing job without answering few of the queries which have been posted here. I would request Dr. Govindraju would answer that question. How frequently do you use these image enhancement techniques? Is it to be done routinely, or is it time consuming? And
No.
does it really add to the cost?
Yes, sir. The equipment is definitely expensive, sir. Currently, the equipment for artificial intelligence stands between 30 lakhs to 75 lakhs for the equipment, depending on the company in which you buy. And we use it regularly, particularly for colonoscopy, sir. It is very useful for polyp detection and polyp characterization. We have a community-based endoscopy system where we do screening for community endoscopy, particularly upper GI and lower GI, for which we use this in community screening to identify them and do a targeted biopsy if needed. So we have been using it regularly.
Thank you. But I feel narrowband imaging has become very common now, and most of the newer scopes have this incorporated technique. I think that itself will enhance, and the quality of image over the years have improved. The resolution has improved. The magnification of the image has improved. So the naturally the pit pattern appearance, the vasculature architecture appreciation, they all have improved the diagnostic, what you call interpretation of the lesions. So I think that itself, if people try to understand how to interpret each of these, will be of advantage. Of course, if you have added advantage, AI is coming up, but it is still in the experimental, I wouldn't say experimental, but at least very early stages. It has got its own disadvantages, as you said. Unless we develop the large amount of database and try to feed this. Probably in future, we may be having more usage of this AI. So, Dr. Joy, would you like to answer? I'm happy that Dr. Abhay Dalvi is watching this, and then he has asked to give few tips of the maneuvers. It's going to be a part of our STEP program. I would encourage surgeons to become part of the STEP program to learn more intricate maneuvers. But you can just say a couple of tips how these maneuvers, big wheel and small wheel, how we use, and then the bending section in few sentences.
You are not audible, Dr. Joy. And also, Dr. Joy, yes.
Yes. Yeah, thank you, sir, to the question directed to me. So you have the big wheel and the small wheel, and definitely your right hand which grips the scope, and the left hand which grips the wheels. So the big wheel moves the scope in the up and down direction, and the smaller wheel moves in the left and right direction. So it is basically your body movements which the wheels enact. Like if you turn to the right, the scope invariably gives a turn. So it is either the wheels you move or you're the body movements. So you can accentuate the wheel movements by moving your body as well. So these are certain, the basic fundamental is to keep the lumen in the center. Always aspire to keep the lumen right in the center. So initially when you start, keep going slow, then crossing the G junction, not a big deal, then crossing the pylorus, and then after going into the pylorus and into the duodenum, you give a deep rotation to the right and turn to the left and turn. That is when you intubate the duodenum. Then these are the basic maneuvers. Then while you come back, you have a retroflexion view where you view the fundus and the hiatus. These are all things said easily, but needs quite a bit of
It
hands-on
needs
practice.
a proper training to understand
Yes,
this. But
definitely,
as you
definitely.
told, retroflexion is a very important maneuver where the blind spots in the fundus around the cardia can be visualized, not to miss some of the G junction lesions as well as early varices, etc. Thank you very much. At the same time, any precautions would you like to take in high-risk patients, especially those who are bleeding? Joy?
High-risk patients, especially, one should be very aware of the coagulation profile. And as in any surgical procedure, if a patient is hemodynamically unstable, try to avoid the procedure as much as possible, unless it is changing the outcome for the patient. So basic blood investigations, you need to be aware, like the INR should not be high because you may need to do a polypectomy or some cauterization or an ulcer clipping or something. So coagulation profiles are very important. So these are all the things which
The basic thing we should not forget is we need to have a monitor. Today, the basic multi-para monitor is a must for even the most healthy looking patient. Ensure that the patient is overnight fasting is there. There should not be any residue in the stomach, which may add even in the healthy patient problem. And make sure the patient takes with a sip of water at least 2 hours early their regular anti-hypertensive medication. Because if they come up overnight, previous day morning, if they have taken blood pressure tablets, the BP would be shooting up already by the time they come in. And on a patient on empty stomach, stress, the BP definitely will be high. These are high chances for complications, not only because of bleeding and the procedures, but also there is a high risk the patient can get cardiovascular and cerebrovascular issues which we have come across. So we need to make sure the blood pressure is normal and they have taken their medications at least 2 hours earlier, which can be a point to be added. And also certain thing monitoring is most essential, and keep your resuscitation trolley ready. Which should not be away. It should have a separate resuscitation trolley attached to the endoscopy unit. So these are basic essentials. You want to add something?
Yeah. Sir, early in the course of your endoscopy, I would suggest most surgeons who are venturing into endoscopy always keep the anesthetist by your side. Maybe the economics may not matter, but it gives you a whole world of confidence. You're really not worried about the monitor, the hemodynamics, and you're just focusing on your procedure. So that is one small tip which I would like to give. Yes, I understand the availability of an anesthetist and the financial aspects are all different, but then it will give you a lot of peace of mind.
Yeah, thank you. I would like to ask Dr. Bhavneet, what are the basic therapeutic procedures which can be started off? How sooner when you start first 100 endoscopy, if you have done upper GI endoscopy, can you start with doing some basic endoscopy therapeutic procedures? What are the things which can
Dr.
be?
Sudesh, we need to close.
Yeah, I
Can
will
it be
take
the
only
last
one
question
question,
is
sir. Thank you.
10:30.
Okay,
Thank
sir.
you, sir. I'll just quickly respond to that. So, what I usually suggest to all the surgeons who are beginners in endoscopy to start by doing some simpler therapeutic procedures. And I basically consider procedures like removing a foreign body, like a coin or a small piece of foreign body, which are what it could be anything. So, foreign body retrievals, doing simple stricture dilatations using either a savory goulard or a CRE balloon, and Dr. Satyapriya sir has so beautifully explained. Just the simple small polyps, thin peduncles. So those are the procedures which I think one should be, and obviously bending. So I think as a beginner, if any surgeon can learn
Sclero
these,
and the
this will probably
dilatation
take care
of
of
simple strictures they can bear.
dilatation of simple using the savory goulard. So these 4 or 5 procedures usually actually constitute the chunk of day-to-day endoscopy practice also.
Thank you. Satyapriya, these colonic polyps and gastric polyps, would they be different? Last question. Or
Only
you
thing
need
is
any
that
special?
definitely colonoscopic polypectomies are riskier because colon walls are thinner, especially the right-sided walls are more thinner. So try to make the saline lip so that it doesn't go into the
So
deeper
a
layers
beginner is
and
safer
give
to start with the gastric polyp.
absolutely the gastric polypectomy. That has the most
Okay.
thicker thing or least chances of perforation.
Thank you. Thank you. I think more questions, you can directly be in touch with any one of us. You have our numbers there on the website. So thank you very much. And we are happy to help you. The STEP program is on, the visibility of which is there very much on the website. And please visit the website, those who are interested to get more details, to get into STEP program, to start your career as endoscopist. Thank you very much for this opportunity. Is there anything else? We are there for you. Thank you,
Thank you.
Santosh. Thank you, Rajgopal Shanai,
Can I
and our
have Dr.
president, Dr.
Thank you, sir.
Bharat Pandian.
Good night, sir.
Thank you,
Thank
the
you.
panel.
Thank you,
Good
sir.
night.
Thank you,
Good
everyone.
night.
Thank you, everyone, sir. Good
Thank
night, sir.
you,
Good night,
everyone.
everybody.
Good night.
Can I request Dr.
Good night.
Sudesh to say a word of thanks, out of thanks?
No, I think we need to have a formal closure.
Yes, sir. Shall I propose, sir?
Yeah, please go ahead.
Yeah. Good evening, all. On behalf of the Association of Surgeons of India, I express my sincere gratitude to all of our faculty, Dr. Govind Rajke, EC member of ASI, Dr. Satyapriya Sarkar, Dr. Bhavneet Bala, and Dr. Joy Abram for an enlightening and practical session on upper GI endoscopy. The clarity of discussion, as you know, the emphasis on safety, sharing of real world experiences have made this program highly valuable and worth coming back to visit again and again. I also thank our moderator, Dr. G. Siddesh, past president and director of Social Welfare Council of ASI, for steering this session effectively, and all the participants for their active engagement. And my sincere thanks to the architect of ASI Time, Dr. Santosh Jan Abraham, past president and advisor to ASI, Dr. Rajgopal Shanai, sir, director academic council. My sincere thanks to Dr. Maruthu Pandian, president ASI, Dr. Pratap Varute, vice president ASI, Dr. Praveen Suryavanshi, immediate past president of ASI. I end by saying we remain committed to continuing high quality educational activities for our members. Thank you. Thank you all.
Thank you very much. Let's meet next week the same time for another round of ASI time. Till then,
Thank
stay
you.
safe.
Good night, sir.